My name's Liza. I am a research coordinator at CenXL RMCR, and also currently serving as the chapter president of the Rocky Mountain chapter of the Huntington's Disease Society of America, which will henceforth be HDSA, because around here we like to have a lot of really long names. So welcome so much. Thank you guys for coming to our annual Family Education Day. Today's event is presented by the HDSA Centers of Excellence at both the University of Colorado Movement Disorders Center and the Rocky Mountain Movement Disorders Center and Movement Disorders Foundation. So again, now you see all the long names, right? Also want to give a thank you to our organizations that are helping sponsor this event. Without them, of course, we wouldn't be able to be here today, wouldn't have this wonderful food that we will also be able to enjoy. So our sponsors are Genentech, Teva Pharmaceuticals, Neurocrine Biosciences, PTC Therapeutics, Mass Mutual Special Care, Picnic Health, and Unicure. Some of our wonderful sponsors have tables set out back, so please, we'll have a break today, and there will be time during lunch. Please go visit, say hi, see what they're doing for the HD community. Also, I would like to mention, we're going to be at some point passing out some evaluations for your time today. So we'd really appreciate if you could fill those out. Let us know what you liked, what you didn't like, what topics you'd be interested in hearing. We're always trying to improve because today is about you. So we want to make sure that we're taking your thoughts into account. So we'll get those handed out, and then you can drop them off at the CenXL table, which is just the first table outside with kind of that white-blue tablecloth. So today, we're going to kick off our presentations with both a familiar face and a new figure in the community. So first, we'll have Dr. Emily Forbes, who is a fellowship-trained movement disorders neurologist at the University of Colorado Anschutz Medical Campus and the director of the HDSA Center of Excellence at the university. She will be accompanied by Dr. Megan Salinas, who's a movement disorder specialist who practiced for several years down in Texas before we stole her away to join Dr. Kumar's practice. And at Dr. Kumar's practice, she will be both very involved in providing clinical care for HD patients as well as helping with the research studies that are conducted there. Dr. Forbes and Salinas will be presenting this morning on HD research and promising new therapies. So let's welcome up Dr. Forbes to start.
All right, so of all the years that I've been giving this talk, I think this year I am the most optimistic. 2024 has been a really exciting year for HD research, hence my title, Progress and Hope, when we talk about advances. So I'm really excited to get started. And the outline of today's talk, we'll talk about a couple of studies that are being done here at the University of Colorado, including a new one on HD sleep and cognition. We'll talk a little bit about a survey study we're doing on uncertainty in HD, and then another one on neurologic music therapy, which some of you have heard about before. And then we'll move on to some genetic therapies. And so first we'll talk about what genetic therapies are, how do they work, and then what research is being done. And so when we talk about the genetic therapies, one thing to remember is those are disease-modifying therapies. So those are ones where we're trying to slow down or stop the progression of HD. So we'll start with sleep, cognition, and HD. So sleep affects brain health. And I think we've all experienced this when we've gotten a really poor night's sleep. And then the next day we just feel not ourselves and not right or not thinking clearly. And so we know that just from experience. And we also know that from research studies. So sleep dysfunction has been associated with cognitive impairment in both healthy adults and in people with neurodegenerative conditions. In other neurologic conditions like Parkinson's and Alzheimer's, this has been studied, and they found that in Parkinson's disease, increased sleep is associated with better cognitive performance, and in Alzheimer's disease, or people with Alzheimer's disease have decreased sleep activity. And there's a little asterisk by the sleep because there are different phases of sleep, and we think that there's one that potentially could be more protective than others called slow wave sleep or deep sleep. So the question has been, does sleep dysfunction or having poor sleep promote deposition of abnormal proteins like we see in Huntington's disease and other neurologic diseases like Parkinson's and Alzheimer's? And so whereas other neurologic diseases, this has been studied, this hasn't been really looked at in Huntington's. But it really should be, because we all know that sleep dysfunction is common in HD. It's self-reported in 88% of people with HD that they have some sleep impairment. It's been shown to be associated with cognitive impairment, mood disorders, and worse quality of life in people with HD and also their care partners. And sleep dysfunction can occur prior to disease onset and worsens as HD progresses. But despite the high prevalence of sleep dysfunction in HD. There are a few studies that use what we call polysomnography or sleep study, which is when we bring someone into a sleep lab and we hook them up to measure their brain waves and see what their brains are doing during sleep. So that's what this proposed new study will do. So we're looking for people with very early symptoms of Huntington's disease who just really started to show symptoms. And participants will complete a thinking and memory test and then a sleep study. So they'll come hang out in our sleep lab here at the university for a night. And then the next morning, we'll have them get an MRI. And that's the whole study for patient participation. And from the information we'll get, we'll try to determine if the amount of protective sleep is associated with cognitive functioning. And part of the reason this is important is because there are ways that we can promote or enhance protective sleep to see if that will help people with HD, specifically cognition in HD, but potentially if this shows good results in other areas of HD or other symptoms that HD affects. So if anyone's interested in hearing more about this, I'm happy to talk to you during a break, or we have Lucas in the back who's at the movement disorder table who can talk to you a little bit more about it as well. The next study that we're going to look at is uncertainty in decision-making in Huntington's. So this is one that involves phone interviews with people with symptoms of Huntington's disease or their care partners. And so if you're somebody who has HD and you want to participate, but your care partner does not, that is okay. You can still do the phone interview. And the goal of this is to describe challenges in decision-making for people who have HD and their care partners throughout different phases of the condition. And so we'll use the information to identify ways to make decision-making easier for people with HD. We estimate the phone interview might take up to 45 minutes and people will be compensated for their time. And the last study I'm going to talk about that's going on here at the university is a study in music therapy and fine motor movements in Huntington's. So there's a whole area of research that's dedicated to understanding how music affects the brain. This study entails an initial visit where people come in for a 3 to 4 hour in-person visit, and they'll get some cognitive testing. They'll get the Unified Huntington's Disease Rating Scale, which is when we have people do the finger taps and the eye movements and walking. And then they'll get a specialized brain scan. And then they'll have 15 visits of neurologic music therapy. And those visits can be done at home. So people don't have to come into that. We can have a music therapist set this up at someone's house, and then they can just do the visits virtually. And at the end of the study, we will bring them back into clinic, repeat all the assessments, and see if there's a difference based on the music therapy intervention. And what we're really looking for here is, can this improve fine motor movements? And so fine motor movements are things like tying your shoes, buttoning buttons, sometimes using iPhones or texting. And so we have a specialized way to test this where we have people do a uniform fine motor movement called a groove pegboard. So people have really enjoyed this study. And if anyone's interested, again, Lucas is in the back, or you're welcome to talk to me during one of the breaks. We're still looking for people to participate here. All right, so let's move on to gene therapy and HD. So the rest of the talk, I'm going to talk about studies that are all looking for a disease-modifying treatment, so something to slow down or stop the progression of HD. So gene therapy is a technique that uses genetic material to treat or prevent a disease. And in order to understand the gene therapy trials, we're going to spend a few minutes reviewing the basics of genetics and genetics of Huntington's. So all of our cells have a complete set of all our genetic information. The genetic information is like a blueprint that goes to make proteins which carry out the function of our cells. But not all of our cells will use every single gene. So for example, our brain cells will use different genes than our liver cells might use because they just need different proteins to work. So we have a complete copy in all of our cells, and in different cells, different genes are called up to make the proteins, and the proteins go on to allow the cell to function properly. And the way it's stored and the way it's used is the DNA that's stored gets turned into a messenger RNA. So it's a different chemical, and then that messenger RNA provides instructions to make a protein. And so it's a little simplified version. So we're going to talk about genetics of HD a little bit more. So every case of Huntington's disease is caused by the exact same thing. A gene, the HTT gene, has extra copies of CAG repeats, so these three chemicals that make up DNA. And this expansion leads to making a protein that is longer and stickier than it's supposed to be. And so you can see on the image on the left here that the top image, there's a normal size protein. So that's the red in the protein section. I don't have a pointer, but you can see on the top there in the red in the protein section, that's a normal size protein. When the CAG repeats are expanded, that protein becomes really long. And when it becomes long, it becomes sticky, and those proteins find each other and stick together and they clump up. And the way I talk about this a lot when I'm in clinic is it's kind of like when you have like a messy house. Oh, great. So when these proteins clump up, they aggregate and they're everywhere. So when our houses or our rooms get messy, we can always clean them up. But it might lead to us losing things or losing our keys or not knowing where things are, tripping over things. And so it's good we can clean them up. Their cells don't have a good way to clean up all these proteins. And so what happens with a cell when all of this aggregates, all these proteins clump up, it's really bad for the cell and the cell dies off. And you can see that in this picture on the left. So you have the normal CAG repeats and then the expanded repeats. And the normal protein is made by the normal repeat. And then on the left side, you see the expanded protein, which clumps up. And on the bottom, you can see all those aggregates. And this happens first and foremost in the deep part of the brain called the striatum. And it wreaks havoc on the cells. And so those cells die off. And this is what really leads to a lot of the symptoms of Huntington's disease. And so this brings up the question, how do we reduce that abnormal protein? So how do we prevent that protein from being made and wreaking havoc on our cells? And so this is where the genetic-based therapies come in. So we're going to review 3 broad ways that we can reduce the abnormal protein and prevent it from aggregating. And so in order to do this, I'm going to show you that DNA to messenger to protein again, but I'm going to show you an image that's a little bit more in depth. So I know there's a lot going on this slide. We're going to take this step by step and look at different targets. And the reason this is so complex is because all of these areas represent targets where we can try to decrease the abnormal Huntington protein. So let's start at the very beginning. So this is just our DNA in our genes. So there are some genetic therapies which can directly edit the makeup of our DNA. This includes CRISPR, and the ZFP stands for zinc finger protein. So CRISPR, I think people have heard about because it's been in the news a lot recently. So recently, the first CRISPR technology for a disease was FDA approved, which is really exciting. It's for a blood disorder, which is very different from a neurologic disorder, but it shows that this technology has come really far in a pretty quick time. And so there's a lot of preclinical work that's being done, meaning not in humans, but preclinical before anything's being tested in humans, to see if CRISPR technology can be helpful for people with HD. And then as for zinc finger proteins, there's also preclinical research going on there, but we're not going to spend a lot of time here. Okay, so this is the next step. So we had our DNA, and now you can see in the pink, this is when it's turned into the messenger. So the DNA in the nucleus on the left is transcribed into RNA, and it's called a messenger RNA because it brings a message of how to make a protein out into the cell. This is a really good place to try to block the message so it does not become an abnormal and harmful Huntington protein. So we're going to look at this for a few therapies. And you can see on the left, it says ASO, small molecules, and then we'll put in a little virus on top of it because those are the 3 we're going to talk about. The reason we are going to talk about them because if we can stop that messenger, we can stop that protein from ever being made. And so let's start with talking about ASOs, the first of the 3. So an ASO stands for an antisense oligonucleotide. How do these work? So like we talked about, when a piece of DNA is needed to make a protein, the area of DNA gets transcribed into the messenger RNA, and that brings the message outside of the nucleus to where the proteins are made. And so if there's a piece of messenger RNA traveling, it's very vulnerable. If we send in a little piece of nucleic acid, like you can see here in red, it binds to that messenger RNA, and our cells know that that is abnormal, and the cell will just use its own inherent machinery to destroy it. This tactic is being used to test potential treatments for many different neurologic diseases and is used currently for other types of neurologic diseases. So for Huntington's disease purposes, there are two broad types of antisense oligonucleotides. So, and it's based on which one of these the ASO targets. So there are ASOs which only target the abnormal Huntington messenger so that the normal Huntington gene still gets turned into a protein. This way, the normal Huntington gene or protein can go on and do its normal functioning. The other type of ASO, which is more common, is one that indiscriminately targets both the normal and the expanded messenger RNA. And there are trials being done in both. Before we talk about those two trials, I want to give everybody some notice that the way that we get the ASOs into the area where they need to be to decrease the abnormal Huntington protein is something called an intrathecal injection. So what that means is essentially that it's very hard to get medications into the brain. So our brain has something called a blood-brain barrier. So when we take medications, those medications don't always diffuse into the space that our brain is. And so it can be difficult to get treatments there. And so the way that these ASOs are getting into the brain space is through a needle, like done with a lumbar puncture or an epidural. So you put a needle in the lower spine and inject the therapy in to the cerebral spinal fluid, and then it kind of diffuses throughout the brain. So the first trial is the generation HD2. So this is tominersen. So I think a lot of us remember a few years ago, tominersen was being tested and the trial stopped because there was some concern that the people who were getting the higher doses were not doing as well, even as the placebo. And so that trial was stopped, but when they went back and they looked at the data, they found that there was a subgroup of people who were a little bit younger and had very early disease onset who actually did well. And so they started another clinical trial just in that group to see if tominersen works. So this is a phase 2 study. It's a placebo, which essentially means it's a sugar pill or doesn't have any medication in it, versus 60 milligrams versus 100 milligrams. The key eligibility for this trial is people should be 25 to 50 years old and have prodromal or very, very early stage HD. And the goals of this are to evaluate for side effects, to see if the amount of mutant Huntington protein is decreased in the spinal fluid, see if there are any changes on imaging in the brain, and changes in function to see if there's any difference in, for example, the ability to move, think, or perform daily activities. And so if anyone's interested in this trial, I think Rocky Mountain Movement Disorder Center is still recruiting for this. So you can you can talk with Liza in the back, who's raising her hand right there, to get more information about this. The update that we got this year for this one was in August. There's an independent data safety monitoring committee. So clinical trials do this where they have just an independent committee that's separate from the trial that looks at safety data. And so that trial recommended that that data safety monitoring committee recommended the trial continue unchanged after reviewing safety information. So that's really good news. All right, so this is the second type of ASO. So this type of antisense oligonucleotide selectively reduces the mutant Huntington protein or the mRNA so that the protein's decreased. And so you can see that the DNA on the image on the left, there's the healthy allele, meaning the healthy version of the DNA. And then on the left side, there's the expanded version. So it only decreases the expanded version. This is just the first time that they've shown that an ASO can do this. It's a phase 1b, 2a multi-site trial. It's being done outside the United States. It's placebo-controlled, double-blind, meaning there's a non-drug given to a group of people, and neither the patients nor the providers know which one they're getting. So data from 23 participants with early HD has been reviewed. We talked about the administration via the lumbar puncture. The primary outcome is always going to be safety and tolerability for earlier phase trials. And the study period results have been released for 28 weeks. One thing to note about this before we talk about the results is that in order to only target that mutant expanded mRNA, they found that there's a little signal on that mutant RNA or the mutant messenger RNA that about 40% of people have. And so this treatment, as it goes forward, would work in people who have that signal, but not everyone has that signal. So that's just something to keep in mind as we talk about the trial. So in June 2024, they came out with data showing that there was a 46% reduction in the mutant Huntington protein in the cerebrospinal fluid compared to the placebo. So compared to the people who weren't getting the medication, they showed that the mutant Huntington is decreased. And so you can see that on the graph on the left. And so the blue line shows the decrease in the mutant Huntington in people who were exposed to this ASO. And the gray line is people who did not get it. They just got a placebo. And on the bottom arrows, those in blue, that's the points at which people got the lumbar puncture, the intrathecal injection. They found also that there was preservation of the wild type or normal Huntington protein. So they knocked down the abnormal protein while preserving the normal one. It was generally safe and well tolerated. And there was also some data that showed that possible loss of brain structures was preserved. So again, this is the first ever clinical trial that demonstrated an allele selective silencing, meaning it's only silencing the abnormal Huntington protein. They released additional data. So this is a different graph on the left. This is the total motor score. And they're seeing in a small group of patients that the total motor score is actually better in the people who received the medication versus the placebo. So again, it's early results with a small number of people, but really optimistic. So we're very cautiously optimistic about this. So now let's focus on something called splicing and small molecules. So what this means is we can provide a drug that alters the instructions to make a protein by changing the code. And so how do we do this? So in the image on the left shows that during the processing of that messenger RNA, an additional piece of genetic information is inserted. And so that's the orange. That's the medication. Additional piece of genetic information is put in there. And when it does that, it essentially tells the cell to just destroy that messenger RNA. And that prevents the abnormal Huntington protein from ever being made. And so that's something that they're looking at in another trial called Pivot HD. This is a phase 2 trial of a molecule, and the study aims to determine the safety and tolerability at any indication that this reduces the level of Huntington protein. And so Pivot HD also came out with some interim results this summer, and they showed that people who took this had a dose-dependent lowering of the Huntington mRNA, so the messenger, and protein levels in the blood. It was well tolerated, so there were no serious adverse events. It did demonstrate that it got into the CSF, so that's a big thing in treatments for neurologic conditions. We want those medications to get into the cerebral spinal fluid. And then they showed that something called NFL levels were stable. So NFL it stands for neurofilament light chain. It's essentially a distress signal that the brain sends out. So we have this for different organs. So if somebody thinks they're having trouble with their heart, we can check for a heart distress signal. They think that NFL is a brain distress signal. So they're starting to watch this in a lot of different clinical trials. And so you might hear companies report on this. And so what they showed is that PTC 518 treatment results in lowering of the mutant Huntington protein in the cerebral spinal fluid at 12 months. And so what the graph shows is on the left, you can see the placebo. So lowering of the mutant Huntington protein occurred by about 9%. With the low dose of this treatment, it reduced by about 21%. And with the high dose, it was reduced by 43%. And so that's really exciting news. It also demonstrated a trend of a dose-dependent improvement in the motor score. So whenever, I'm not sure if anyone here has done a clinical trial, I think most people have been evaluated. We make you do the finger taps, we'll make people move their eyes around, we'll make them walk, we'll try to pull them backwards. So that's what they mean when they're talking about the motor score. And so the lower it is on this graph, the worse the motor score is. And they showed that the people who are getting the placebo had a worse motor score than people who were not. And then a few other data points they released. They released the UHDRS, so the full score. So the worsening, again, the lower you are, the worse it is. And people who were receiving treatment did better than the people who are on the placebo. And the total functional capacity. So function is something that we can improve the motor score, we can improve various other measures. We want to make sure people are still functioning well in their life. That's a key measure. And so they showed that people who were taking the treatment did better than people in the placebo from a functional capacity, which is great. So they have said that they are beginning preparations for a phase 3 clinical trial. Again, really exciting news. And so with that, we're going to move on to the third way that we can prevent Huntington protein from being made. And that means we're going to look at the viruses. So this is a phase 1/2 clinical trial of a product called AMT-130. So it's a gene therapy that's delivered directly into striatum, so that deep part of the brain. And the goal, again, is to slow disease or prevent it from progressing by interfering with the production of protein. So this is delivered by a one-time neurosurgical procedure. So in order to get this therapy to work, we have to have access to the DNA deep within our brain. And so it's a hard place to get to. And we've been talking a little bit about that, about how it's hard for our drugs to get into the spinal fluid and into the brain. And so we're going to talk about how treatments can get into this area. So first we'll talk about how this drug can get into our cells, and then we'll talk about how it can help decrease the mutant Huntington. So there are two main components of AMT-130. The first is something called a viral vector. So viruses are able to infect us because they have this shell, which you can see here on the image on the left. And the shell tricks our cells to letting it in. And a normal virus that might infect humans will trick the cell to letting it in, and then on the inside of the virus, it has all this viral particles that have our cells' machinery replicate it. However, not all viruses cause problems for humans. There are a lot of viruses out there that we interact with that we just don't really acknowledge or know that much about because they don't really infect us. And so adeno-associated virus is one of the viruses that is not a problem for humans. And so what scientists are doing is they're taking the shell from that virus and removing the interior. So they're removing all those viral particles from the middle and they're putting in a therapy. So what they're putting in the middle is something called microRNA. So small pieces of genetic material that can prevent the production of an abnormal Huntington protein. And ideally, the cells would use their own machinery to keep producing this for a long time, potentially even for life. But that obviously has to be evaluated as clinical trials go on. So how do we get the therapy into the striatum, that deep part of the brain? Well, that's another tricky process. So it's a one-time neurosurgical procedure. There's a little hole that's drilled into the brain and a tiny catheter is put in to infuse the therapy. So there are two trials ongoing for this treatment, HG Gene TRX1 and 2. So 39 participants have received either a high dose or a low dose or a sham surgery. So there's some placebo controlled here. We've hit the 2-year mark. 12 people have received the low dose and 9 people have received the high dose. And the data that was released this summer showed that AMT-130 high dose significantly reduced disease progression by 80% using the UHDRS at 2 years out compared to natural history. So one thing to note is this doesn't have its own group of placebo. It compares it to people who have done, for example, Enroll HD or Prevent HD. So we know what the natural history, the normal progression of HD is like. And so it also showed that there's a difference between a low and high dose of AMT-130. And so in the image on the right, you can see that there's disease worsening the lower it is. And so all the way on the left, that's the external controls. So that's the people who have HD, who have been in other studies where we just monitor them over time. And there's improvement in people who are in low and high dose of this therapy. And so another really exciting development. So with that, I want to thank everyone for coming this morning. And I wanted to give a big thank you to everyone who has participated in a clinical trial and everyone who has supported someone who's participated in a clinical trial. I think it's a very brave thing to do and it shows a lot of commitment. And I think the talks that we have this year really show the breakthroughs that we've had because of the dedication of people who've participated. So thank you so much, everyone, for being here and for participating in trials. And so now Dr. Salinas is coming up for her talk.
And thank you, Dr. Forbes, for going over the genetics of Huntington and some of the science that's going on. I'm going to continue on that vein and talk about other research trials that have been completed or are currently ongoing and some that are enrolling. Okay, the only disclosure that I have is that I have salary support from CenXL. All right, so these are the trials that I'm going to go over. Luckily, I don't think we overlapped much, Dr. Forbes, so we planned well. All right, so the first one I'm going to discuss is the Annexon trial. This targets the complement system in the body, and the complement system is part of your body's mechanism to clear out infections, cells that have been damaged. So what happens as we develop, both in utero, so when you still are in your mother's tummy, and also as a child, is that your brain continues to grow additional brain cells, but not all brain cells are needed to form the networks. And so there's a pruning process that goes on to take away the extra brain cells that weren't needed that your body made. And so this is a normal process through development, but as an adult, you don't need to prune your extra brain cells. Your brain is done growing, those circuits have been made, and the particular part of the complement system that was involved with pruning back the extra brain cells is no longer needed. And so it should be deactivated. And that's where this trial comes in. So it's looking at a particular complement, C1q, and looking to see it's being reactivated in neurodegenerative disorders. So that includes Huntington's. So it's trying to start pruning back or help clearing out damaged cells when it really shouldn't be active. So it's been shown that there are higher complement levels in the spinal fluid of HD patients. And it also goes along with the severity of disease. So the image on the left, you can see the different stages of Huntington's. So as the years go by, individuals will develop more and more symptoms of Huntington's, motor impairment, cognitive impairment, and then chorea. And so we try to designate these different time points as pre-symptomatic, prodromal, and then manifest HD, having symptoms early, moderate, or advanced. And so then when we have this knowledge of the different stages, you can look at the different complement levels and see that really compared to healthy controls in blue, that individuals with early manifest and moderate manifest or moderate amount of symptoms have significantly increased levels. So this looks like a good potential target. All right. So the diagram on the left again shows the complement C1q, and you can see that there's a bunch of C's scattered in different colored circles below that. And so the C1q triggers a cascade of inflammation and attacks on your own body cells, and in this case with Huntington's, brain cells. And so it does it in a variety of different ways. So it will attract other immune cells to come to the area to help clear out damaged cells. And it can also destroy the kind of membrane or outer coating of a brain cell. All right. So this is not necessarily unique in Huntington's. This is also being looked at in other neurodegenerative conditions as a possible treatment. As you can see, both for ALS, commonly known as Lou Gehrig's disease. Okay. So there was a 24-week trial enrolling 28 subjects, looking at pre-manifest and early manifest, and looking at the safety and tolerability. Again, just like Dr. Forbes mentioned earlier, the phase 1 of these types of studies is primarily looking at safety. Now, their secondary endpoints, they do sometimes look at efficacy. And so they're looking at to make sure that patients have lower complement levels, that their idea of reducing this complement activation cascade is working. All right, so this is some information. It's kind of a busy table about the patients in this Annexon trial. And so it's showing that compared to all patients, and then the Track HD is more of a natural history cohort. And so you can see that they are similarly matched, as well as having similar research scale scores. So the total functional capacity, the composite UHDRS. And so the different groups are very similar. So we can also test to see if they have would have similar results or improvement in their scores. This has been very well tolerated. And so this is the side effects of the Annexon treatment. So for the safety population, again, they enrolled 28 people. Most all had a slight rash during the first treatment that was self-limited. Other than that, you can see that the dizziness, nausea, vomiting, headache were mild side effects, but overall, there were not any what we consider grade 4 or life-threatening or highly disabling side effects. So overall, a well-tolerated treatment. Okay, so looking downstream, the picture I showed earlier showed that C1q and then others complement that it will activate in the cascade. So we can measure these other complements to see if they've actually been activated or not. And so you can see in the diagram here that it does reduce the number of downstream complements that are activated. So it works. Oh. All right. And so we can also look at individuals who have baseline complement levels. So, and I'll show more on this on the next slide, but essentially with the natural history studies, they were able to look at the baseline amount of complement level and then stratify into two groups: individuals with HD that have a very high amount of complement activity, and a group of patients that does not have a very high. In fact, they have a low amount of complement activity. Okay, and then so we can see that in the green is the higher amount of complement activity, and in blue is the lower amount of complement activity. So patients with a high amount of complement activity at baseline showed that they had more rapid and sustained clinical improvement on the composite UHDRS compared with individuals who had a low baseline complement activity level. So just like Dr. Forbes mentioned earlier, that there was a marker to see if you would be a responder for the treatment. This is another way to identify patients who may be good responders for this treatment, is to get their baseline complement level. All right, and so this is also showing the two groups again, with high and low complement activity. On part A, you can see at 24 weeks that the individuals with a higher baseline amount of complement activity had a more improved score as compared with those who had lower baseline activity. So this also goes into what I was saying before, that the individuals who participated in this trial, also some of them were a part of the natural history trials. So we were able to see what their baseline complement levels were. And so again, the low complement is in, I think, blue, and high complement levels are in red. And so you can see over both the composite UHDRS as well as the total functional score, and then cognitive scores on the bottom there show that those with high complement levels have the better outcomes. So we're hoping that treatment with Annexon appears to slow the rate of decline of HD, both in motor and cognitive scales. All right. So again, this is a well-tolerated treatment, and with this being non-unique to Huntington's, is a promising treatment strategy for other neurodegenerative conditions. Clearly, finding out the patients who have a higher amount of baseline complement would be helpful to know that they would have a good response to this treatment. And we're still waiting for the company to start larger phase 2-3 studies. All right. So we're going to go on and talk about Proof HD, which studied a compound pridopatine. So this is a small molecule investigational drug. Again, not unique necessarily to HD. It's also being used in another neurodegenerative condition called ALS. And the nice thing with this medication is that it's oral, so you don't have to have a infusion or intrathecal treatment. And so it works by binding to sigma-1 receptor, or S1R. This is a receptor that is expressed in brains, and it has an important role when the brain is stressed or damaged to help kind of rescue those brain cells. And so activation will lead to decreased brain cell death, increased health of the brain cells, and promote the circuitry to be viable and continue functioning as it's intended. And so with the activation of this receptor through many different ways, it can help as a neuroprotective agent. So you can see here, it helps your brain clear out bad proteins. So Dr. Forbes did a fabulous job telling you all about the abnormal Huntington protein. And so this could help clear out those abnormal ones. It makes sure that your brain cells produce enough energy to carry out the normal functioning. And it can also, again, reduce inflammation. So there's a phase 3 trial, double-blind, placebo-controlled, and it's looking at 480 early HD patients, looking at improvement in the functional score. So this is just some information, probably a little too detailed for what you want to know, but looking again at the total functional capacity, making sure that we're actually improving patients' lives with the treatment and not just finger tapping size. And also looking at different areas that we track with Huntington's, not just motor function, but also cognitive function as well. And interestingly, before the trial started, they wanted to look at 3 different populations of patients. So one group of patients were not on any medications that would block dopamine. So that's considered a neuroleptic. And then also they were not on medications to treat chorea. And so both neuroleptics that block the dopamine receptor and medications for chorea like VMAT2 inhibitors that reduce the dopamine levels. So the reason I'm going into that in just a minute is that it actually makes a big difference on the response to this treatment. And so this is the tolerability and safety profile. You can see that it's actually pretty much the same as placebo. All right, so the primary endpoint, looking at the composite score of the UHDRS, actually didn't show a large improvement compared to placebo. However, why I went into all those other medications. So if a person was not on chorea medication or neuroleptics, then they actually had a significant benefit from predopamine. And so whether we don't know, but whether this was because it helped patients who had less severe symptoms, or it helped with, preventing an interaction with those other medications to treat chorea, we don't know. And so hopefully future studies will look at in patient populations that aren't on those extra medications if we can have better benefit. And so the company Bulinia is actually looking to see what their options are for approval through emergency medication through the FDA. All right. So for predopamine, again, the primary endpoint was not met. So that's unfortunate that it won't help all comers for Huntington's. However, we do know that if somebody is not on those medications or has very early disease, that maybe this would still be a very helpful treatment. Okay. And so this was recently published data on the subset analysis this year. All right. So SAGE HD is looking at a modulator of another type of receptor on brain cells called NMDA. And so this receptor can play an important role in both cognitive and behavioral functioning of a person. And so it is known that in Huntington's, these types of receptors are dysfunctional. And there's overall in early Huntington's reduced level of a chemical called glutamate. And so the SAGE HD trial is looking at this modulator, or basically a compound that changes the activity of the NMDA receptor in the brain so that it'll work more appropriately. And so it was thought that maybe this would help with the cognitive behavioral symptoms that often occur in Huntington's. And so there's 2 different studies that I would like to discuss. So there's the Dimensions study. And so this is looking at 178 patients for approximately 4 months on drug and then a 1-year follow-up. And so this is looking at the cognitive functioning of individuals with pre-manifest or early manifest HD. Then there's Surveyor. So this is a 80 participant trial, also enrolling half of healthy controls. It's shorter, it's 2 months. And again, pre-manifest or early manifest disease. This is looking at cognition again in Huntington's. interestingly, this one has some unique testing. And so they have a virtual reality driving simulator and that we are able to see in terms of a much more functional importance for a patient as opposed to the total functional capacity or finger tapping, things like that. And so the results from Surveyor were announced by Sage Therapeutics just this past June. The study was not designed or powered to find if it had an actual statistical significance between the product and placebo. However, it did show that what we know is that the composite cognitive scores that they looked at for HD patients were much more impaired than for healthy controls. And hopefully we'll be looking at additional studies for this compound. All right. So we're going to move on to another way of trying to get Huntington's proteins kind of knocked down. So this one is looking at, it's Ask Bio, and it's looking at the role of a particular type of cholesterol in the brain. So cholesterol is important for making up the cell membrane. So that's the outer layer of brain cells. It also is very important in the brain circuits. So when the brain cells are talking to each other, it helps to release the chemical signals. Also very important for cell function. So this is probably going back to high school science for most people, but the mitochondria is the powerhouse of cells and makes energy. So if this is damaged, then the brain cell or other types of body cells will not be able to function and will die. And so being able to support not just the outside membrane structure, the signaling, and the energy maker, it hopefully will be neuroprotective. All right. So with this slide, you can see that disturbances in brain cholesterol are thought to contribute significantly to neurodegeneration. And again, this is not necessarily unique to Huntington's, but one of many targets as you've seen today. So you can see that without the regular function of brain cholesterol, excitotoxicity means that your brain cells are firing and working too hard, that eventually that's harmful to the brain cell itself and others that it's connected to in the circuits. It has difficulty being able to maintain its normal functioning as well and leads to brain cell death. So the particular cholesterol that was being studied in Ask Bio is a 24-hydroxycholesterol. It's a mouthful. And we can see that these amounts of cholesterol are decreased in blood levels for Huntington patients. So looking further, it was found that this cholesterol is very important for a particular type of enzyme that also helps make other cholesterol and will affect brain regions that are impaired with Huntington's. So you can see on the graph on the left that you have control subjects and early manifest HD. You can see that the 24-hydroxycholesterol levels are lower. And then the total cholesterol between the two groups, control and early HD, are about the same. But then you have the ratio. And again, the ratio is lower with early Huntington's. This is showing two different areas that are very much affected by Huntington's. So the cortex is very important for cognition and behavior and motor planning. And you can see that HD patients have very high levels of this enzyme protein, whereas in another area of the brain, they do not have high levels. So these are the potential areas that it can target. So how do we get the cholesterol into the brain? So very similar to the virus shell that Dr. Forbes was talking about. This is a virus shell that encodes for a protein that will convert cholesterol that's in the brain into that good cholesterol that we are wanting. And so this was done by a very similar injection to the catheter approach from the Unicure study. All right. So again, the idea with the Ask Bio is that this is a neuroprotective treatment and targets many different pathways to support brain health. And so you can see that the phase 1-2 endpoints here, we'll talk about that. So safety, of course, is, for phase 1 and 2, the main endpoints, but then also looking at the different changes in cognitive and motor function scores. So we will look forward to hearing the results from that. All right, so we thus far have talked about disease-modifying treatments. This is a symptomatic treatment study looking at valbenazine. So this does not alter the disease course, but can help symptomatically. Valbenazine is a dopamine depleter medication that works by decreasing the release of dopamine into brain circuitry. And so right prior to this study, it was already approved for the treatment of tardive dyskinesias. Now, looking at tardive dyskinesia, you can have a lot of chorea with that. And so the sponsor decided to look at Huntington's chorea to see if it would also benefit. And so, in fact, they did just that. And you can see here that overall, the valbenazine group and the placebo arm were very similar in their demographics. And overall, you can see on this plot that you have the mean change in UHDRS, total chorea score, relative to their baseline. So you can see the x-axis is time, how long they've been on the treatment, and the y-axis is the change in the amount of chorea that they have. So you can see that the blue placebo arm had very little change in the amount of chorea, whereas the treatment arm with valbenazine had significant improvement. And so it was recently approved for HD chorea. The most common side effects with this medication were sleepiness and fatigue. All right, so we can talk about one of the natural history studies that is ongoing, Enroll HD. I think I saw a few hats out there. But essentially, this is looking as an observational study for individuals who have symptomatic HD, but also pre-manifest HD or at-risk individuals. So the main goal is to help us better understand HD. It involves a once-a-year visit. What they collect is blood samples for biobanking so that future scientists can look at markers of HD or potential treatment targets. So overall, as of May of this year, 31,622 participants have been recruited from about 155 active sites around the world in 23 different countries. All right, and so again, the goal of Enroll is to increase the understanding of Huntington's, to monitor the symptoms and see how they change over time, to better inform clinical trial design in the future, as well as provide a good control population that can be compared to any potential future treatments. All right, and then finally, we'll talk about HD Clarity. So this is a study to look for biomarkers of HD. And so for this, an individual will undergo a lumbar puncture with spinal fluid collection that is banked. And also with the spinal fluid, individual scientists or companies can request access to, again, develop novel treatment strategies. And so this is still ongoing. So why should someone have interest in participating in a clinical trial? So although we do not have any FDA-approved disease-modifying treatments for Huntington's yet, this is a way to potentially have access to those treatment options prior to FDA approval, to contribute to the scientific process and, help inform sponsors, scientists, so that they can come up with a cure, hopefully in the very near future, and also to help future generations. Another benefit of being involved in a clinical trial is that you have frequent medical monitoring. So often patients will be seen on a more frequent basis, have their medications evaluated. So just a reminder, just as Dr. Forbes has many studies available at CU, there's also many available at Rocky Mountain Research. So there's a table outside, and also Liza here, who's the MC, can help give you more information about trials ongoing. We are enrolling the natural history study as well as disease-modifying trials. So in that sense, most everyone who is, a family member or they themselves affected by HD can participate. All right, and I know most of you are used to seeing Dr. Kumar up here giving these updates. So a big thanks to him for letting me have this opportunity to speak. Of course, our patients who motivate us to do what we do every day. So this is a QR code to the research website if you're interested. Thank you.
First, I'd like to welcome Kelsey. She's a genetic counselor at the Colorado Center for Reproductive Medicine, CCRM. She works with people pursuing IVF and embryo genetic testing. Before her role at CCRM, she worked in prenatal genetic counseling. She completed her genetic counseling education at Augustana Sanford in South Dakota, but has lived in Colorado for 8 years. So let's give a warm welcome to Kelsey.
Yes, my name's Kelsey. I'm a genetic counselor at CCRM. I'm really excited to be here today. Thanks for inviting me to join you and speak today about what I do, which is pre-implantation genetic testing in an IVF setting. So this is something we're able to offer patients for a variety of different inherited genetic conditions, Huntington's disease being one of them. And just to be absolutely clear, I am an employee of CCRM as well. So I wanted to talk about, there's a number of different, of course, risk-reducing reproductive options when there is a genetic condition in the family. I am going to particularly speak about assisted reproductive technologies. So that's going to be closest to me over here, PGTM, along with things like gamete donation. But of course, we know there are options like adoption and prenatal testing as well. I'm not going to go into too much detail about those, but they are available options. In terms of genetic testing, PGTM, that's our pre-implantation genetic testing for monogenic disease. That is what allows us to test embryos before transferring them into the uterus for pregnancy and reducing risk that way. And then, of course, gamete donation reduces the risk through either egg donor, sperm donor, or embryo donor. So we have lots of couples choosing a variety of these different options. If IVF or assisted reproductive technologies feels like the right fit for your family, what are the first steps towards making that happen? So you would need to basically present as a new patient at CCRM or at the fertility clinic and meet with the physician. So this is going to be a physician that specializes in IVF and reproductive endocrinology and infertility. And then you will do a routine fertility workup. So just like any other patient at the clinic, you will go through fertility testing that might include like hormone testing, ovarian reserve testing, semen analysis, ultrasound, just to see what your eligibility standards is for IVF. You will, of course, meet with a genetic counselor as well, and we'll sort of talk through what the process will look like. And then the embryo testing itself actually takes place at a specialty lab called Reproductive Genetic Innovations out of Chicago. So have a referral over to them. They'll sort of talk through the process with you. One thing that is very, very important to note if you decide you'd like to go through this process is that we must have some sort of documentation that there is Huntington's disease in the family. So that can be either a positive test report for the patient, that could be a positive test report for a family member, or it could just be medical documentation that it's in the family. So it doesn't necessarily have to be genetic testing, but we have to have some sort of official documentation that the patient is in fact at risk for Huntington's disease. And then once everything is set with RGI, the process to set up the embryo testing does take about 4 to 6 weeks on average. So it is kind of a lengthy process. Once the probe setup is ready and RGI confirms we're ready to go with testing embryos, we begin our thing at CCRM in terms of IVF cycles. So we do ovarian stimulation, medications in order to proceed with like an egg retrieval, and that takes 4 to 6 weeks as well. So I'm sure you're gathering this is kind of a lengthy process timeline-wise. In terms of just what is IVF? So IVF stands for in vitro fertilization. And this does require, like I mentioned, that 4 to 6 weeks of ovarian stimulation, and then it does require an egg retrieval surgery. So we actually go in and retrieve all of these eggs that we've recruited. We fertilize them in the lab, and then we grow those embryos out in the lab for about 5 or 6 days. We like for them to be large enough that they can be safely biopsied. So once they reach this safe stage at day 5 or 6, we will gently remove a small handful of cells, usually 3 to 6 cells per embryo. We freeze the embryos, and then all we're doing the testing on is those 3 to 6 cells that we've gotten per embryo. And we're actually going to be performing 2 tests on this DNA, the first of which is sort of like a chromosome viability test, and then the second would be the Huntington's disease testing. We're able to do both of those tests on just that small handful of cells. There's a couple of different ways that you can go about testing for HD in embryos. This is going to be the more quote unquote straightforward way. This is when a patient presents to us and they have a personal positive test report. So we know that they personally have or are at risk with Huntington's disease. And so we know in this instance, there is a 50-50 chance then with each conception or each child or each embryo to inherit it. This is when all cards are on the table. So we will disclose the results of your fertility workup to you. You will know, generally speaking, how many embryos that we're hoping to get for your IVF cycle. We'll know how many we expect to pass the chromosome viability testing. We'll give you a better idea of your prognosis. And then at the end, you'll get a report and you'll know how many embryos were created. You'll know their chromosome status. You'll know their HD status and everything like that. So the next is a little less straightforward. This is what we call non-disclosure. PGTM. So non-disclosure pre-implantation genetic testing, it actually does not require that the patient in front of us knows their Huntington's disease status. So this is a great option for people who don't want to proceed with testing or don't want to proceed yet. Basically, what makes this a little bit tricky though is everything is blinded from the patient. So RGI, that testing lab that will eventually do the embryo genetic testing, they are going to completely de-identify and actually test the patient for Huntington's disease. But that result is never disclosed to the patient. It's not even disclosed to CCRM. So your physician won't know your status. You won't know your status. Nobody in the building will know your status. And all of your fertility workup is blinded to you as well. So you will not know going in how many eggs we're expecting to retrieve, how many we're expecting to fertilize, how many we're expecting to pass the chromosome testing piece. So there is no way for you to deduce based on the results of your workup whether or not you may or may not be at risk. So this is a great option. What does make it a little bit tricky is it is very gray going in. So you do kind of have to go into the whole process blind. But ultimately at the end, you will know, yes, you have, the embryos available for your desired family size, or no, you don't have enough embryos available for your desired family size. You will not know whether they were, if we just didn't get enough because of a fertility workup, we won't know if they're excluded based off of chromosome status or HD status or anything else. So we get a lot of families who choose this option simply because they prefer not to know their status. Okay, I should have given you a warning shot before I put up this slide. So estimated costs, unfortunately, I think we can all understand that IVF is just generally speaking a rather expensive process. I have put up general numbers for self-pay price. So this is not including any insurance. This is not including any grants or anything of that nature. Those things are available. Colorado is, especially in Colorado, insurance coverage is quite a bit better than it can be in other places. But just to give you an idea of potentially max out-of-pocket costs. So the diagnostic testing for IVF, so this is just determining fertility status. It can be around $4,000. The IVF cycle, including the embryo transfer. So again, that's the egg retrieval surgery. And that 4 to 6 weeks of ovarian stimulation, that can be quite pricey as well. The genetic testing with RGI is an additional cost. And then I've also included the gamete donor costs as well, in case that route makes more sense, depending on your preferences. So I know that was kind of an intense slide, but I will end on just the genetic counselor's contact information. So this is the email for the genetic counselors at CCRM. There's 4 of us, and our direct phone number. We are happy to talk with families or individuals at any point at no charge to just review this process in more detail, especially the things like cost, insurance coverage, next steps, what the testing looks like. So please feel free to contact us at any point in time with no commitment, no meeting with the physician. You're welcome to contact us at no charge, and we're happy to answer any questions you have.
Hello, everybody, and I'm going to explain a little bit about what our chapter does and what's involved, and how it all kind of fits into piece with the national group, and as well as our centers of excellence, which we just touched on a little bit, what our center of excellence do. First of all, my disclosure is I was gene tested in 2005 and had a 42 repeat. I guess I still have the 42 repeat. It hasn't changed. And quickly got involved with the chapter, and been a very strong advocate in research. And as Liza mentioned, I've been involved in a dozen plus different research studies over the years and continue to participate. Just had my clarity lumbar puncture a few weeks ago. So, and I'm still here. And second of all, a big thing about our chapter, and I forgot to put a slide in here about it, is we were recognized last year as the chapter of the year out of 50 plus chapters across the country, just for things that we do, our support groups, our educational events, our fundraising events and such. So we have a very exciting chapter here in Colorado, and it's been fun to watch it grow and ebb and flow over the years. This is our Rocky Mountain Board of Directors. We got a really good group of folks right now. We have people that are involved from Grand Junction. Monica there puts on the Team Hope Walk in Grand Junction, and she's our vice president. A lot of these people are here in the room. So if you want to talk to anybody about being involved or getting involved with the chapter, please let one of us know. Our overall quick mission, and this is something we came up with. As she mentioned, I was a planner, so I always come up like mission statements, and this is to improve the lives of everyone affected by HD, and the Rocky Mountain chapter, in particular, our community here. What we do, we provide support through our support groups that we have. We have two well, actually, we have three. We have two for folks that are affected by HD. We do one national one and one that's local. And then we also have a one that is for caregivers that meets on a quarterly basis. So we also have a social worker. So if you want to talk to a social worker and getting involved in some of the things with our centers of excellence, I'll talk a little bit more detail on the centers of excellence in a few slides. But our the social worker, we just have a new one. Beth, can you raise her hand? We just she just started with us in here in the last month, but she's here to get to know everybody, and she can get you started down those paths and who to talk to at our centers of excellence and such. And she works for us. We have her for 20 hours a week, which is usually about twice as much as any other chapter does in the country. We do advocate for change. I've met in the past with my local congressman to talk to him about HD, to get him to support the HD Parity Act. We've had other people from our community meet with their representatives. Um, Kind of taking a different approach right now on the national level as far as advocacy. And it's always a challenge during election years because you have a whole new Congress that comes in, and you got to kind of convince them all over again if there are new people coming in and such. So I'm sure there'll be a lot of things coming up on the advocacy side of things coming up after the elections and into the year 2025. Just build awareness. One of the things that we've done with our social worker in the past is get them out in the community, give them chances to meet with law enforcement, emergency responders, the medical community, also care facilities to help them understand what HD is. So when they see people with HD or people, that's something that they can consider and they've heard about it. Raise funds that support the research and the family services, such as our support groups, things that we do here. I'll talk about some of the fundraising here in a couple slides. And then amazing research that we have going on. And all this together will keep that hope alive and our team hope rolling along. A little bit about the social worker again, just provides that. We have a hotline that you can call and get in contact with our social worker if you want to get involved in genetic testing or have questions about it, what it's involved. Um, Again, our support groups across the state on this evaluation that that was passed out to you during the break. Please take a chance to take a look at that. We're trying to get the support groups going back and having an in-person opportunity to get together for educational events as well as in-person support groups. We have meetings here in Denver, over in Grand Junction, and then we have the virtual meetings also. And so we assist and partner with our local centers of excellence. I kind of oversee quarterly meetings that I have with both Dr. Forbes and Dr. Kumar, and now Dr. Salinas, and talking and making sure that we're meeting all the needs of our HD community here in the region. Building that outreach, getting out and talking with folks around the country. Man, the slides slid around a little bit, but another big thing is working with those long-term care facilities, and then also one of the things that we're really starting to strengthen up is our working with the National Youth Alliance. The slide there, the picture's kind of slid up there. But that's a real big goal of ours. We used to have a very active youth component to our chapter, and now we're starting to get that started back up again. Again, some of the information about the HDPRD Act, which is still moving forward, the Healthcare Reform Act. We have gotten some hard fought gains. We had some health insurance access that got improved. And my understanding on this is that there was somebody that had an HD connection back in Washington with one of those departments, and they were able to speed some of this stuff through and get some of the healthcare things moved a little bit faster for people filing for Medicaid and such. Uh, we educate again through our food for thought education. So that's something that we started here in this chapter. And we continue to try to push where we have an hour type educational event that's provided with food, so that on your way home from work, you can stop in, grab a bite to eat, and then learn a little bit about HD. And we have different topics that range about financial planning, insurance coverages, all those kind of interesting questions that people always have because of the complexities of getting those kinds of things when you have an HD. We lead these annual symposiums and work in collaborations with the Centers of Excellence to put these on. We typically have this once a year. And that's another important thing when you're filling out your evaluation. Please put down what type of topics you were wanting to have. What we got last year is we had a few of them that mentioned the IVF. So when we started getting together and talking about that this year and putting this together, I mentioned we got quite a few questions or about IVF and maybe having a presentation on that. So we do pull from these topics, and they also help us give us ideas for those food for thought events. So please, if you have things that you would like to see or hear a conversation on, we can get that on the board here. Here's some of the things that we do for raising money through our events. We have a celebration of hope that's kind of held over at a wine bar. Our next one will probably be here in spring of 2025. The Heroes and Villains 5K race for Huntington's disease is held nearby here over at Denver Central Park, and it's held the beginning of September each year. And the Fairway of Hopes golf tournament is held out at the beautiful Arrowhead Golf Course out by Roxborough, and that's held in July. And gentleman back there, Justin, will be able to, if you're a golfer, that's your thing. Um, we have fundraising appeals. We kind of go out and meet with different people to get support for these different events. We have an amaryllis sale every fall, and a number of other third-party events. I know Meg was talking about having a fundraiser next year. She's one of our new members on our board, and doing a yoga event coming up here in 2025. So stay tuned for more details on that. And then just recently, we started again our drag queen bingo, which we sold out all our tickets during a snowstorm. So we're looking for a bigger venue to increase that. Who would have guessed? Um, Again, we just are a very outgoing, embracive community with our chapter. So if you'd like to be involved, you can get involved, but we're here to support you in any way you need. So reach out to the many resources that we provide. And you can find things on the web. Just type in Rocky Mountain chapter HDSA, and you'll find our information there. I've covered a lot of this stuff already. But on to our centers of excellence. This is a really big thing that HDSA started, I want to say about 22 years ago, because I heard about it when I first picked up the phone in 2003 to find out about getting gene tested. And I called the HDSA Rocky Mountain social worker at that time. And they go, "Oh, we got this new thing called Centers of Excellence." And I go, "What's that?" And they go, "Well, the Center of Excellence, there's there's people that know all about HD. They're the experts. They'll be able to advise you. That's the where to go through to get testing." So honestly, and I'll just share my a little bit of my personal experience. I went in to get tested and find out about that. Met with that team of experts that interdisciplinary team that included a genetic counselor, a psychologist, or yeah, psychologist, a, a neurologist, and a social worker to just kind of find out where I was with this in my head, as well as financially, and as I moved into the process of getting tested. And they have a certain protocol that they go through to get tested. So you just don't get hooked up with and have somebody mail you a gene test. Some of the horror stories that I've heard about people finding out if they're gene positive or not. They're very methodical and thoughtful about this and help you weigh what all the different implications of this information might be. So I will plug Centers of Excellence until I'm not able to do that any longer. And we are so lucky here. We have two through a lot of effort of our board to keep these. They are supported by a grant yearly that comes from our national HDSA, and our chapter writes a letter of recommendation to our national office to support these two centers of excellence. The only other metro area in the country that has two is Chicago. So fortunately, here in the middle of the plains and the mountains of the Rocky Mountain West, we have two located right here, and they both have, are both amazing facilities. The the Movement Disorders Foundation over by Swedish Hospital. They were one of the first ones that were established. That's where I got my gene testing. And actually, Dr. Kumar was recognized for that in New Orleans as one of the first centers of excellence that was established. It's also one of the few or one of two in the country out of 53 that is a nonprofit. It's not a university based, which just allows him to get a lot of involvement from the drug companies to get extra people into different studies. We also have monthly clinics at both of those centers. That's what the grant primarily is used for, is support these monthly clinics. They're free clinics to people. You just need to get in contact with those centers to come in and get some evaluations and have a conversation with folks at those clinics. Get the genetic testing using that HDSA protocol. And they also help us with these types of events here. We have here in Colorado some of the largest research trial enrollments in the world. We are constantly having the most people in the generation study, the most people in some of these enroll studies, and the clarity study. And that's just because we have a very active research community here, as far as people providing the research, as well as people wanting to participate in the research. And I know they bring in people from all over the country here to participate in these trials.